I want to thank Pastor Beverly Knox for inviting me to be a part of this today, and I'm grateful and honored to be here with y'all today. This is a great organization, and it means a lot to our community. So thank y'all again for being here, and I appreciate the opportunity to share with you. I'm Dr. Lynn Hogan. I'm a doctor of clinical psychology and licensed professional counselor here in Mississippi, and I work for Weems Community Mental Health Center. Before I forget, I want to let you know I do have a lot of information up here and some little freebie squeezy things that say imagine on them for some reason. I don't know why. It says imagine. But I'm going to talk today about a diagnosis. I diagnose just about every day of my working world. So literally hundreds and hundreds and hundreds of times a year. But I don't diagnose post-traumatic stress disorder, PTSD, very often because it's a relatively infrequent diagnosis. However, when I do diagnose PTSD, I know I'm dealing with a very serious condition. Things that precipitate someone having post-traumatic stress disorder are fairly distressful to an individual. Now, it's true that we all have had some type of traumatic event, perhaps some type of setback or something like that. But to meet criteria for post-traumatic stress disorder, there has to be a significant event that actually has affected that individual in a very significant way. And it has a lot to do with how our mind works. And our mind is amazing. The Creator gave us this amazing brain. And I want to speak just a minute about memory. When I teach at MSU, I teach memory courses, cognitive psychology, clinical psychology. I teach a course called Sensation and Perception and a host of others. But one memory course that I teach helps break down the different types of memory that human beings have, such as working memory, short-term memory, long-term memory. So I want to see a raise of hands. Tell me if you can tell me, or raise your hand if you can tell me your first landline phone number. Raise your hand. Yes, ma'am.
601-483-6577, and I still have it.
Oh, wait, you still have it. Okay. All right, tell me. You're stealing my phone. Okay, I'm going to look. Okay, when was the last time you called that number? Over 5 years ago. How was she able to recall that number literally in just a few seconds, and she hasn't had that number or thought of that number in 5 years? Now raise your hand if it's been longer since you thought of your first landline number, but you still remember it. Why is that? What's your phone number? What was it? And when was the last time you thought about it? Just a minute ago. Did I have this is a comedian show? What's put out here? Sometimes it can be literally decades, but we'll remember things. Those are what we call, go ahead. Did you raise your hand? And who's that? Over 25 years ago, and you recall it in what, 3 seconds? Here's the point. When information transfers from working memory to short-term memory to long-term memory, we never forget it. We'll always know our birthday. It's called biographical memory and things like that. When we talk about trauma, specifically post-traumatic stress disorder, what happens with that traumatic event? It becomes imprinted on the mind, and then it becomes encoded in the long-term memory, and people just don't forget it. Do you remember the old notary public stamps? And you put the piece of paper in the notary public stamp and print it? Remember that? Now they just have a stamp, I believe. But it would put a demarcation on that piece of paper, and it never really goes away. That's what happens with trauma. So I'm going to get into it briefly. I wish I had the rest of the afternoon to share with you. But PTSD is a very dangerous, if you will, condition that needs to be addressed properly with somebody that knows what they're doing regarding treatment for it. So I'm going to jump right in. and talk about the prevalence of PTSD. I'm going to read from down here if I can see it. Post-traumatic stress disorder affects 3.6% of the United States adults. That's 9.4 million. That's a lot of people, and believe you me, there's not enough psychologists and therapists for us to treat that many people. So there's a lot of people running around there that have it. Affects 3.5 million adolescents. 1 in 11 will be diagnosed with post-traumatic stress disorder in their lifetime. Women are twice as likely to acquire the diagnosis of PTSD. And we can all surmise logically why that could potentially happen, right? Yes? So the question is, why would some people develop PTSD and some not? And what I found clinically in my practice is that I can have, for example, 2 women, same age, have a similar event happen to them, let's say a sexual assault. And one perhaps gets some help and she carries on with her life. Yes, it was a significant event for her, but she's able to continue with her life and her quality of life and be functional. The other one, it may ruin her life and she can be dysfunctional the rest of her life. So what delineates and why would one person be resilient to such a thing and some not? Well, there's so many variables involved, pre-existing conditions that we look at. It's kind of beyond the scope of what I'm sharing with you today. But I want you to know that a traumatic event can be subjective, meaning just the individual's interpretation of what happened to them is kind of what delineates whether it's a trauma to them or not. And of course, we also want to discern if it's distressing to them or not, because some people, I would imagine if I was able to go around, y'all could probably tell me some things that have happened to you, but you know what you did? You kind of carried on. Why? Because we have to in life. We all encounter things that we have to kind of carry through. So some people develop PTSD and some do not. We do know that all mental health conditions and substance abuse disorders comes from 2 different places, genetics and environment. So genetics kind of lays the foundation for these type of things to occur, and then an environmental event like a trauma can kind of set it off. So you can have somebody with a strong genetic load for, let's say, depression, but they may not get depressed unless something significant happens to them. So I just want to tell you that there's a lot of different types of traumatic events. I just got a few listings together here. Combat veterans, which we hear about most often. If you remember 9/11 from the Twin Towers, Katrina back in 2005, right? Sexual assault, natural disasters. Imagine what's going on with those folks in Asheville, North Carolina, and Boone, North Carolina today. And then also the people on the Florida Gulf Coast due to the hurricane. Childhood sexual assault. I want to let y'all know, I hear too much of that. I practiced up in Missouri for almost 10 years. I thought it was bad up there. I've never seen anything like sexual assault of children until I moved down here. It's amazing how often I hear that. Motor vehicle accidents, medical conditions, shootings, death of loved ones, prior exposure and chronic stress, acute and chronic pain conditions due to a disease process or some type of injury. It can be something as innocuous as an embarrassment or a personal setback. Anything outside the range of what that individual typically experiences in their life could be traumatic to them. And please understand, it is subjective. So some people will experience a trauma, some will not, depending on what it is. It's amazing, too, the resilience that we have. So when we diagnose PTSD, someone that's experienced an exposure to an actual or threatened death, serious injury or sexual violation, and they've either directly or indirectly experienced a traumatic event, or they witnessed a traumatic event, or they learned about the event from a family member or a friend, so if something significant happened to a friend. It's what we call secondary traumatization, vicarious traumatization. First responders deal with this a lot. We as counselors deal with this because we hear a lot of things that are happening to people, and we're not callous to that. Our job as counselors is to be empathic and understanding. Repeated or extreme exposure to a traumatic event, and it can be through the media or pictures or something online or movies. Behavioral symptoms, when someone is meeting criteria for PTSD, that they may re-experience that trauma. And sometimes out of the blue, sometimes while you're asleep, or sometimes if it's something that triggers them. So there's recurrent, distressing, intrusive memories. So what's important there, the key word is intrusive memories. Remember that memory's there in the long-term memory function, but it's now intrusive. It's coming to them out of the blue, and they don't like it. It's very distressing to them. They can have flashbacks of what happened. Dissociation means kind of an out-of-body experience. They think that life isn't real. And then there has to be distress. So I know I'm dealing with somebody who has PTSD is when I get them talking about the trauma, they become very uncomfortable. They can become agitated, and I can tell they may not really want to talk about it. And sometimes I have to stop and say, listen, why don't we take a minute and calm down, and maybe we can explore this in our next session, whatever it may be. And I always try to find out their comfort level in talking about it. Behavioral avoidance. One of the first people I ever treated that PTSD was a bus driver up in Springfield, Missouri, and he'd been driving a bus for 20 years. Well, unfortunately, one day, a bicyclist came in front of him. Well, he hit the bus, hit him, and the man died. Well, it took me 6 months to help that man actually get back into a bus because he avoided getting on a bus. And I worked with his employer, and we were able to get him back driving again after he was fairly intense treatment that I helped him with. But he could not do the same route, but he could drive a bus again, which was important to him. He wanted to continue doing that. So we first efforts to avoid the distressing memories, thoughts, or feelings, efforts to avoid people, places, and things, or conversations about it. Maybe you know somebody that's a combat veteran. I hear these stories about Uncle Frank or my grandfather. He would never talk about the war. Maybe y'all know people like that. They just won't talk about it. They just don't want to go there. It's very distressing to them. Behavioral symptoms, negative cognitions. Cognitions means how we think. So they'll have negative mood or thinking about it. Inability to remember certain aspects of it. Negative beliefs. And here's where it kind of turns on them. They may have negative beliefs about themselves, like maybe they caused it, particularly victims of sexual assault or childhood sexual abuse. Okay? Maybe somebody has said, hey, well, maybe it was the clothing you were wearing. Well, that is all untrue. So I do a lot of damage control with sexual assault victims and victims of childhood sexual molestation, and make sure they understand that was not your fault. That was his fault or her fault. So we have to do that too. Blaming self for the cause of the trauma, persistent negative emotional states. Persistent negative emotional states is part and parcel to depression. Depression means that you're going to automatically think negative. You could actually win the lottery, and if you're depressed, you'll think, well, I'm probably going to lose the money, this isn't going to work out well. Depression is really amazing. It not only makes that person feel sad or hopeless or down, it actually causes the most optimistic person to think negative thoughts. Depression is an amazing event. But that's part and parcel of PTSD, to be sure. Diminished interest in activities, and that's got depression written all over it. Feeling detached and estranged from others. Persistent inability to experience positive emotions. Arousal means you may have irritable behavior or anger outbursts, verbal or physical aggression, reckless self-destructive behavior such as substance use disorder, hypervigilance, problems with concentration, sleep disturbance, again, comorbid or co-occurring with depressive symptoms. And it causes significant distress. Now again, if somebody says, hey, I had this thing happen to me, and I'm thinking to myself, my gosh, how is this person handling this? But it's not causing them any distress. And I'll try to ask them, okay, you sure it's not distressful to you? No, I'm okay with it. Okay, fair enough, right? I'm not going to plant anything on them. But for some people, they've been through a lot of stuff. Raise your hand. Yes? Been through a lot of stuff. And we tend to be okay with it in most cases. So it has to be distressing. Now sometimes too it has delayed expression. I diagnosed a Vietnam War veteran 3 years ago that had not been assessed, and he incurred a traumatic event in Vietnam like in 1969, 1970. But when I did an assessment, I went through the criteria, he met criteria for post-traumatic stress disorder. He's been suffering all these years and never got any help. It just broke my heart, but he's getting help now to be sure. He's a wonderful man. I want to know, this is what when I teach diagnosing and at the university, I'll go into something called the hypothalamic pituitary axis and how the brain takes in the information and it encodes it. And there's a word up there called the amygdala complex. And no offense, but it could be beyond the scope of what we're talking about here. But what is a very intricate thing that happens to the brain that affects our emotions. And that's because we're kind of set up, the Creator made us this way. And that's how it affects us. There's simple and complex PTSD. That simply means that if it's simple PTSD, that's probably just one event that happened. But if it's complex, which I see a lot with childhood sexual abuse, it's been ongoing and long term. And one of the problems I see, certainly with childhood sexual abuse, is I want to know who did it. Was it a relative, friend of a friend? Was it a parent? And of course, if it's a parent or a relative, that lends itself to a bigger problem, if you will. So there's a broad range of symptoms. There could be self-harm, suicide, this is Suicide Awareness Month, here the 30th of September. And of course, tomorrow begins Substance Abuse Awareness Month, which is October. So we're right here on the cusp of that. So suicide is part of association, losing time, problems with relationships, memory, sexual health issues, anger, shame, guilt, numbness. All these things are part and parcel, and then feeling damaged. And that's one of the most heartening things I hear from somebody is that they feel damaged about this. Dr. Couture, who's a board-certified psychologist, wrote in her book, "It's not you, it's what happened to you." Trauma involves the spirit and is dispiriting by its very nature. Trauma is an assault on the spirit and the self. Trauma involves a shattering of self-definition, identity, life assumptions, and meanings. The trauma of a child abuse has been called soul murder. That is profound, that terminology. One incest survivor says, "I have a hole in my soul." That's what she writes about in her book. "I'm not the person I might have been." That just breaks my heart. Can you imagine someone telling you that? I'm not the person I might have been had this not happened to me through no fault of my own. That's why they need counseling, someone who's going to try to understand and try to understand the heart. So it's comorbid means it can occur with major depression. I highlighted substance use disorder because that's one of the most prevalent ones. Panic disorder, agoraphobia is a form of panic disorder, OCD, generalized anxiety disorder, social anxiety disorder, specific phobias, bipolar disorder. They can either come before, during, or after the PTSD. So very often when I diagnose PTSD, I'm also diagnosing another diagnosis, a comorbid condition. And I'll be honest with you, usually it's substance use disorder, namely alcohol use disorder. Okay? You can have lots of different types of substance use disorder, but what we find is people with PTSD that's untreated, they tend to drink a lot. And I understand why, because the alcohol actually helps them deal with and cope with some of the symptoms associated with that trauma. So there's different paths that connect PTSD and substance use disorder. I want to say one thing about substance use disorder. It's prevalent, 75%. I won't go too far to that, but I want to show you this. Now, as a substance use disorder therapist, I've been treating people with substance use disorder for about 25 years. And one of my mentors is here, Mr. Gene Coleman. Gene, love you, Gene. We work together treating people with substance use disorder. It's a tough disease, and it's a disease of the brain. And this was an excerpt from Neuropsychopharmacological Review. There's a mouthful. That actually details, I've read through that several times. I put this up here for effect. I don't expect you to read that. But that shows all the neurological things that happens when someone is abusing drugs or alcohol. It is profound. And it affects them biologically, psychologically, socially, and spiritually. So in reference to treating, as we finish up today, to treat PTSD after we've done a diagnosis, know at first it presents a serious challenge. And we have common practice modalities. The first one is something called cognitive behavior therapy. Certified in that. I'm also certified in TFCBT, which is trauma-focused cognitive behavior therapy. Motivational interviewing, dialectical behavior therapy. These are just acronyms for these things we have to learn in school, or that we get to learn in school. EMDR is the gold standard for treating PTSD. I'm not certified in that. I refer out for people that know how to do EMDR. It stands for eye movement desensitization reprocessing. When somebody I'm working with doesn't respond well to cognitive behavior therapy, then I'll refer them out for EMDR. And it's a really good treatment. It's like the gold standard these days, heavily researched and very effective for people that have trauma. The goal is not to erase the memory, because we know that'll never happen, just like we talked about remembering our phone numbers and things like that. It's to help them learn how to manage the thoughts and feelings when they come. And sometimes they can come out of the blue, right? So skills and coping mechanisms, clinical hypnosis, interpersonal therapy, solution-focused therapy, stress inoculation therapy, exposure-based therapy. Exposure-based therapy is what I did with the bus driver, whereas we had him learn to relax and then go and look at the bus and then eventually get on the bus and just sit in the driver's seat, eventually pull it out of the parking lot. So we slowly but surely, through exposure, got him where he was able to run a route again and he could continue working, which was important. And then there's pharmacotherapy. We do assessments. This is what we'll do in the office. We'll do assessments to discern kind of where they are with their level of trauma. And there's a bunch of different ones. I use the Beck Anxiety Inventory, the Beck Depression Inventory. We want to treat people with dignity. We want to ensure their confidentiality, compassion, unconditional positive regard. I don't care what they've told me. They're still a human being. They're a child of God.
Amen.
I don't care if they smell when they come in.
Amen.
It doesn't matter to me. That is a human being that's deserving to be respected and treated with dignity, without fail. And if you ever go to a counselor who doesn't treat you that way, fire them and come see us.
Okay, Doctor.
Advocacy, I want to advocate for them, ongoing counseling, housing, employment, social skills. We do those type things at Wings. That's what I love about that company I work for. Emotion management, stress management, mindfulness, treating the whole person. Again, we're going to treat them biologically, psychologically, socially, and spiritually because trauma affects them biologically, psychologically, socially, and spiritually. A protocol that I developed over the years is to establish rapport, have them describe the trauma and get it out. There's something called psychoneurolinguistics that when someone talks about the trauma, they tend to problem solve and it helps that emotion get out and it helps them kind of put things together. So just talking about it. So I may have them describe the trauma in the first session, if they will, and then the second session we're going to do it again. And we may do that for 10 sessions just to get them to go through it, to kind of desensitize, but to get that out. Complete psychological tests. I'm going to assess their depression, anxiety, substance use disorder, and do a medication evaluation. We're going to explore how they think about the trauma, something called CBT. Might put them in substance abuse treatment, and then, of course, complementary alternative medicine. So in other words, there's a lot of things we can do to help somebody with trauma, but we can't help them if they don't come in. They don't need to suffer in silence. If you think somebody has trauma, tell them to give me a call. I'll be happy to meet with them. Do a free screening, have a cup of coffee with them, say, hey, what's going on? What can we do to help? All right, that's a brief idea about how we diagnose and treat PTSD. I hope it was helpful for you. Thanks again for the opportunity.
Since we have two speakers, I'm gonna go ahead and let Mr. Couch come on up as well, and then if you got questions, just
Just hold on a few minutes, and then we'll get your questions.
Thank you. First, I'd like to thank Beverly and Michelle for having me here. I appreciate the opportunity to tell people about Stronger Together and what we do. Following Dr. Hogan here he did a very good job of describing everything. And I want to tell you a little bit. I want to tell you a little bit about military, PTSD, and where a lot of the statistics come from. As Beverly introduced me, I'm 26 years Air Force veteran. I served in the Air Force and Air National Guard. I had the honor of working with many renowned people, men and women. I also saw the profound effects that PTSD took on many of my fellow veterans. Shortly after 9/11, my unit was deployed, and we made a promise to each other that we would all make it home safe, and we did. But tragically, after we got home, our youngest member took his life. Suicide is a tragedy that touches all of us. In 2023 alone, more than 50,000 Americans, veterans, civilians, and first responders lost their lives to suicide. That's according to NBC News. That's 50,000 families shattered by a loss that didn't have to happen. For our veterans, the numbers are even more heartbreaking. 22 veterans lose their life to suicide every day. The statistics has become a powerful rally cry across social media and echoed by many public figures. But where did that number come from? In 2012, the U.S. Department of Veteran Affairs released a report based on 21 states. They found that 18.3% of all suicides were people who served in the military. However, many death certificates didn't indicate whether it's veteran status. So, with the data they had, it was incomplete, but based on the data they had, they estimated that 22 veterans were dying by suicide every day. Since then, that number has become a rally cry and a call to action. In response to these numbers and statistics, the military, alongside the VFW, the USO, and the American Legion, they've launched incentives to tackle this crisis head on. These programs are crucial with support to veterans dealing in PTSD, anxiety, and depression. It's estimated that 7% of all veterans will experience PTSD in their lifetime. But it's important to remember that veteran suicide aren't just a result of combat. There are many factors at play: frequent deployments, remote duty stations, long stretches away from home, and job-related stresses. A lot of times after 9/11, when we were deployed, we were having briefings in country, and we were told that 9 out of 10 people you see want to kill you, and you have to work in these conditions. A lot of times we flew into the countries at night, and you could see the lights of the runway, and they'd go out, and then the lights on the plane would go out, and we would land in total darkness. A lot of us was, hey, we won't do this again, this is fun. But a lot of them were scared to death to get on another plane. And it took some doings just to get them on planes to get them home. So there's a lot more to it than just combat. As of 2023, over 190,000 U.S. troops are deployed in 178 countries around the world, enduring various challenges, which can add immense pressure. The National Guard in particular has seen an increase in operational tempo in recent years, which has put even more stress on its members. And then there's transition from active duty to civilian life. Once a service member decides that he's wants to get out of the service and go back to work in the civilian aspect, there's increase in challenges such as financial instability, employment difficulties, relationship struggles, and substance abuse. Sometimes isolation could create additional pressures. And then for our older veterans, loneliness can be especially tough. And as Dr. Lynn said, that PTSD can resurface. And sometimes our veterans suffer alone, and we've got to get them talking. Many of our National Guard and military members fill roles in our communities, such as first responders, police officers, firefighters, and paramedics. They face similar challenges. Every day they witness trauma, suffering, which can have significant impact on their mental health. Studies show that first responders are more likely to experience PTSD and anxiety than the general population. And sadly, they are at a higher risk for suicide, just like our veterans. First responders need our support and resources to cope with the mental toll of their service. Suicide can result from a variety of overwhelming stressors, financial pressures, relationship difficulties, anxiety, just to name a few. Sometimes it happens impulsively in moments of intense emotional pain. That's why it's important for us to recognize warning signs. They include withdrawal from loved ones, giving away prized possessions, engaged in risky behavior, talking about or making plans for suicide, expressing hopelessness, or showing signs of emotional distress. This is why Stronger Together's mission is so critical. We need to continue raising awareness, offering resources, and above all, reminding our veterans and first responders that they are never alone and there is always hope and there is always help. If you or anyone you know is struggling, please don't hesitate to reach out. Crisis intervention teams, CIT, are available through partnerships with local law enforcement to guide people to the appropriate care. And remember that the 988 Suicide Crisis Line is available 24 hours a day, 7 days a week. Finally, if you are interested in supporting the Stronger Together Foundation and the work we do, I would love to talk with you. We are always looking for compassionate individuals who want to make a difference. And I also like to recognize any veterans we have here. I'd like you to raise your hand, and I thank you for your service. Along with that, I would like to thank the families of veterans, because y'all are the ones that deal with us after we come back. And we appreciate you, and we would like for y'all to be recognized. Thank you.